Kia ora, everyone. It's so lovely to see all of you online today. As you know, you've probably had a chance to have a look at the flyer. This is an important topic for the Pacific region. It is the first of our webinar series for the New Zealand College of Public Health Medicine, and of course, we've got working partners that we're working with the University of Auckland team, as well as WPRO, SPC, and other stakeholders, including UNAIDS and the Departments of Health for Papua New Guinea and Fiji Ministry of Health. So we're very, very happy to have you on board today. Now, we're going to kick off with Dr. Nano Gideon, and he will introduce himself. He will do that well, and then go straight into your presentation. Dr. Nano, over to you.
Thank you, Aumea, and thank you, other colleagues from the Pacific. I am Dr. Nano Gideon. I'm the National STI HIV Program Manager with the National Department of Health. So it is my pleasure to join this public health webinar on HIV in the Pacific. So maybe, Aumea, you could help me get my slides. Do I start now?
Pam, did you send your slides to us? I thought you would control your slides.
I haven't sent it. I'll probably try and share it.
Yeah, you should be able to share. You shouldn't have a problem. Yeah.
You know, at the bottom there's a green button with an upgoing arrow, and then you just share to us. Watch out, you might share other information on your laptop.
Okay, I'll do that. Is it showing?
Yes, well done. You just need to push the button on your laptop that makes it into one slide, because we can see the side slides.
It's the start slideshow button, if you can find the start slideshow button.
Go to slideshow at the top, if that's easier for you.
Okay, slideshow.
Mm-hmm.
And then from beginning.
And then I'll say
From beginning.
Okay, from beginning.
Perfect.
Is that okay?
Okay,
perfect.
All yours.
Yeah. Okay, thank you so much. Thank you for having me to speak on behalf of the Papua New Guinea Health Department about HIV. First of all, I want to acknowledge what I am going to present on behalf of the National Department of Health is a culmination of the collaborative efforts by all our development partners, the government of Papua New Guinea, the faith-based organizations, the civil society, and many leaders who have led the programs in the past. So what I'm going to present is basically all of our collective efforts going forward. I'd also like to take this time to acknowledge the organizers of the webinar focusing on HIV in Pacific. For us in the Pacific, all of us are living at the time where a lot of things are happening, emerging and re-emerging diseases, but HIV has been one disease that's really affecting our community. So it's good that I'm going to represent the country to talk about HIV. So in my slides, I only have 7 slides to share. Slide number 1 will be about PNG. I'm from Papua New Guinea, so I'll just talk about the country, its population, and then a bit about the epidemic in PNG, the statistics in the last 14 years, starting from 2010, some of the achievements, some challenges, and the plans for the National STI HIV program, as per the National STI HIV strategy that we have developed from 2024 to 2028. As you can see on the map, we are part of Oceania. We are more towards the northwest of Oceania, to the north of Australia, positioned north of Australia to the west of Solomon Islands. And as you can see in the green is Papua New Guinea. So Papua New Guinea has a total population, it's made up of 22 provinces, about 105 districts, with about 12 million people, slightly more women than men, 1:2 ratio, male to female. We have a land area of 452,860 square kilometers. Geographically, it's a very challenging country. We have rugged terrains, maritime provinces and islands. Culturally, it's a diverse country with 860 language groups. So as you can see, when you have a epidemic like HIV, it's very hard to disseminate information across such a country. But what I'm going to present to you is what we have achieved in the last probably 22 years. As you can see on the graphs that I have for us, it's the HIV epidemic and response going back to June 2024. And what we have from 2023 is the new infections globally have reduced by 39% from 2010. However, in PNG, from our statistics, we have seen that HIV has increased by 103% since. So it seems to be one of the highest across the world, and it is very concerning for the government at the moment. The estimated rate of HIV infections in PNG is about 18 new infections per day, which puts us at around 6,700 in 2023 per year. But the latest data that we have has already shown that we've actually, it's even higher than that. So we're waiting for forecasting for 2024 to come forth. So our national prevalence is 1%, which puts us as about 77,000 people living with HIV across the country. Deaths, as indicated by the green line on the graph, is still high, but is stabilizing at less than 1,000 per year, and then we have an estimated 33,000 deaths which were averted to the increase in ART coverage since 2010. So talking about the antiretroviral coverage, we have, as ethically, if you test, you have to have treatment. So for us, we have about 400 testing sites across the 22 provinces. We are present right down at the districts, and the number of people diagnosed, treated across 165 treatment sites, which spans across the 22 provinces. So we have averted more than 33,000 deaths as a result of the increase in ARV coverage that we have had since 2010. In 2023, a number of countries have achieved the global HIV targets. However, PNG is still struggling to achieve that. So for the 95, we have, for us, we have 76, 84, and 91. So which is about 58,514 people out of the 77,000 know their status, and of that, about 49,000 are on antiretroviral drugs, and about 31,000 have done a viral load. So viral load suppression is about 91%, but the struggles or challenges that we're having to try and get the platforms for gene-expert platforms across the country is still happening to bring the numbers in. So HIV epidemic in the country, as I have stated, is a mixed epidemic concentrated among key populations and the sexual partners. So it's one of those epidemics that we're really trying to understand, because it seems to be shifting between the general population and the key population. And when it comes to key population discussion, it's a very difficult situation that we usually have across the country. The main route of HIV transmission in PNG is through sexual transmission, and it's found to be among key populations and the sexual partners. female sex workers, male sex workers, and men with diverse sexualities are seen to have a high rate. So in the last biobehavioral survey that we had in 2018, just some years back, shown that we have about 16 and 18% among sex workers, and about 8% prevalence among MSMs and transgenders. So as you can see, we have many challenges as well. Criminalization of transgender people, criminalization of sex work, criminalization of same-sex acts have been a big challenge because we have this clearly stipulated or highlighted in the criminal law. So it's very hard for key population groups to come out and get redress or be addressed or be properly served in the safe spaces. So there is a non-existence of some of the factors contributing to our epidemic is the non-existence of HIV prevention and outreach in majority of the provinces. Because there was a time that we used to have such preventions happening across the country, but when the epidemic slowed down, the government closed certain aspects of the prevention programs that were driven by certain agencies, and now we are back on that. We are back. Our numbers are still up, so we're looking at how best we can address those. Condom distribution and is a challenge. Condom use across key population is low, although we have testing coverage across the 22 province. Testing uptake is also low, and that continues to place a burden on us as we are moving through. As you can see, the epidemic, the statistics that we have collected have shown that we need to understand the kind of population that we have amongst the key population. So the sex workers, the men who have sex with men, and transgender groups have been identified across the country, and we have the estimated numbers as indicated. The global target for HIV testing among pregnant women was set at 95% by 2025. However, in PNG, only 22% or 23% of pregnant women were tested in 2023. So as you can see on the graph, a significant number of women come to the clinic. Estimated number of pregnant women in PNG, about 253,000 plus. But only half of that come for a visit. And even if only half of them come, about less than 50% have been tested. And as you can see, only 1 in 5 pregnant women know the status. And an estimated 2,600 estimated number of pregnant women are living with HIV in PNG. And of that, about 1,515 receive ART, and a smaller number. So you can see, so the vertical transmission in PNG remains stubbornly high at 30% in 2023, and this translates to about an estimated 800 new infant infections due to mother-to-child transmission. So 2 babies are born with HIV per day in PNG as of 2023. So this number continues to grow, and it's really concerning. And now we are trying to re-strategize and try to move into areas where we can try and mitigate those infections. How do we do that? We have developed the 2024 to 2028 National STI HIV strategy, which has been launched, unfortunately, in 2024 in November. And now we are really looking at how best we can try and put in more prevention interventions across the 22 provinces. That's pillar number 1. And pillar number 2 is to try and ensure we sustain the gains that we have made in terms of care and treatment, to make sure that those who are diagnosed are quickly put on treatment and virally suppressed. But we also know that we cannot treat ourselves out of the epidemic. We have to do other things to make sure we prevent new infections. One of the things that we have, one of the issues that we have seen is there needs to be leadership on the ground. And in the past, we have been managing HIV program as a national program, more or less like a remote control from the national system, trying to control the provinces. But now we are looking at building strong coordination, robust systems, and supportive environments within the 22 provinces so that they can take care of the people within their own province and be a part of the fight against HIV going into the future in the next 5 years. So we have a strategy in place that is now on foot. And having a strategy is one thing, but funding the strategy has been a real challenge in the last 2 or 3 strategy in PNG. So as you can see, our strategy has been costed to be about 1 billion. It's about between 200 to 250 million US dollars for 5 years. So it's a significant amount, but when spread over 5 years, it's about 50 million per year over 22 provinces. So we are trying to mobilize those resources. Although we have sent the strategy, the government is not, send the strategy into the government systems. The systems have not churned out the resources that we require. So we continue to get very limited resources, and we are really working closely with the development partners to try and address the different aspects of the HIV program in this country. So as you can see, we have epidemic that is more or less like getting out of hand, and we are trying to re-strategize and move into the prevention space, more like moving upstream to make sure the young population, those who are at risk, are better managed, and they're getting the services that they require within their own safe space. I think that's my last slide. Thank you for listening.
Thank you so much, Dr. Nano, Gideon. That's fantastic and quite a sobering presentation. We see the challenges you are faced with in Papua New Guinea. I'm happy to have one question, and then we will move to the next speaker. And at the end of all presentations, then we'll open up for Q&A. Do we have a question from anyone? I can't really see.
Thank you. You're welcome.
No? Let's move on. Our next presenter is Dr. Jason Mitchell, and I'll leave it to you, Jason, to introduce yourself. Thank you.
Yeah, thank you very much. So my name is Jason. I'm originally from Fiji, and I started my HIV career by establishing the HIV services in the northern part of Fiji. I then went on to establish a regional program for professionals who work in the HIV space across the region, which cover the 22 countries and territories, the smaller countries outside of PNG. So health workers who work in STIs, HIV, and sexual and reproductive health. I then moved on to work in a country that had a concentrated HIV epidemic, which is important for our discussions today. I worked in Myanmar in UNAIDS for a number of years before returning to Fiji only recently. I've actually returned to Fiji to spend a bit more time focusing on reproductive health. And then on my return to Fiji, this HIV situation came to be publicly known. And so I'm now currently engaged through DFAT funding to provide direct support to the Ministry of Health of Fiji under the HIV board as the chair of the National HIV Outbreak and Cluster Response Taskforce. So that's kind of giving you an indication of what my talk is on this afternoon. So I'd just like to share some of our lessons learned and challenges from Fiji. I'm actually presenting because the Permanent Secretary for Health, who is the chair of the HIV board in Fiji, has asked me to present on his behalf. Unfortunately, he's not able to make this presentation. And I would also like to acknowledge my colleagues from the Ministry of Health who provided the majority of the epidemiological slides that we'll be discussing this afternoon. I have a lot of slides to cover, so I will probably try my best to just read the slides so that I don't go off track. I have a tendency to sort of go off track. So I'll just very briefly go looking at the current epidemiology of HIV, epidemiology of HIV in Fiji, just provide an update of our current HIV estimates, look at like an overview of some of the challenges we're facing in this response to the current outbreak, discuss a little bit about how we've come up with this definition of an outbreak, and share some lessons for the region and opportunities for us to consider. So just a brief summary of the HIV situation in Fiji. So Fiji, as of January to September 2024, we diagnosed 1,093 cases. That's a 98% increase compared to January and June last year, when we only diagnosed 552 cases. This increase, there's a 163% increase from Jan to December 2023. So, it's a significant increase. The majority of cases are adults, 98%. We have a serious concern here in Fiji about the increase in maternal to child transmissions of HIV. 2% of our 1,093 cases are in children, in children from the ages of 0 to 14. But we've had 18 cases of maternal to child transmissions. Fiji is divided into 3 administrative divisions. The majority of cases are in the central division, where the capital is, where 70% of our cases are. And the second highest is in the Western Division, which is just close to 30%, and the Northern Division, where I started my career at, is 3%. The majority of our cases, 71%, are in males, and in females, 28%, and transgender, 1%. I think what's really important is for us not to let this data dictate what actually is going on, because we don't have a very good targeted testing program here. So I'm always cautious when interpreting some of this data. So in terms of the cumulative number of cases we've had over the years, since we first started diagnosing cases in 1989, since 2024, we have accumulated and diagnosed 3,170 cases. Okay. In terms of just like a discussion around the new HIV diagnosis trends over time. So between 2019 and 2021, Fiji had a relatively stable HIV epidemic, with a modest rise in cases diagnosed between 13.56 to 17.06 per 100,000 between 2019 to 2022. From 2023 onwards, the diagnosis surged dramatically. And it jumped significantly to 123.52 per 100,000 in 2024, which is a 9-fold increase compared to 2019. So in terms of sex distribution, in earlier years, you could see from the graph that the sex ratio is relatively balanced. But then in 2022 onwards, the male cases began to rise disproportionately. And by 2024, males made up the majority of the new diagnosis we're seeing here in Fiji. The shift actually might suggest a concentrated transmission among male networks, especially amongst people who inject drugs and other male groups. We don't have enough information to say this for certain, but this is what we have based on clinic information that we have on hand in the national program. The trend reflects both a generalized epidemic across age and sex groups. And when I say generalized epidemic, I don't mean in the way that UNAIDS might define it, in which we say in a generalized epidemic that there is over 1% prevalence in the general population and over 5% in subpopulation. I'm just saying that there is an increase in cases in all subpopulation groups in the country, including young people. So this pattern really does suggest that we've moved from cluster cases to community-wide transmission of HIV. In terms of being a multi-ethnic country, the majority of our cases in Fiji are amongst the indigenous population of the Itaukei, which represents about 90.6% of all transmissions in 2024, followed by Fijians of Indian descent, which made up about 8.2% of our population, of the cohort of people living with HIV. In terms of the age group analysis, the majority of our cases, as you can see here, are aged between the ages of 10 and 29 years. So 60% of our cohort are in this particular age group. So it's the young reproductive age group. I would like to just highlight our concern about the number of adolescents, which make up 9% of all our transmissions here in Fiji. I just want to highlight that in this particular graph, which when you analyze our clinic data and you look into the actual age groups, you can see that adolescents enrolled in care that we are starting to see more and more adolescents who are reported to be HIV positive. And when you compare that to the previous 3 years, there is actually a 45-fold increase in the number of adolescents who are diagnosed in 2024 compared to the previous 3 years. So, there's a lot of concern here, particularly when you consider that there's no specific, just like our colleagues in PNG, our prevention programs that are targeting this particular group is really limited. So when looking at the modes of transmission by age group, so you can see that the epidemic is focused really in men between the ages of 20 to 29, where diagnosis has nearly doubled, those of females. This age-sex distribution highlights the need for targeted testing and prevention and care strategies focused in young men, including MSM, transgender, and PWID. I won't go too much into that, so I can just move on to the next one. So we did some analysis of people enrolled in care. And the reason why we focus on those enrolled in care is because 50% of our cohort of people who are known to be HIV positive in Fiji have not been engaged in the health service. And so therefore, we don't really know much about what their risk factors are. So of those, the analysis we did of 443 people who enrolled in care in our clinics, the majority of them were injecting drug users, and they were known to be the most common mode of transmission, particularly for those aged between 20 and 34 years of age. In Fiji, we have stopped using the terminology such as, heterosexual or homosexual. And when you see PTA, that means penis to anus transmission, which accounts for transmissions among MSM and between males and females who engage in penis to anal sex. And the rates are actually increasing in all these risk behaviors right across the board. So in terms of our mortality, in 2024, we reported 150 age-related deaths, which is a steep rise compared to previous years. And what's interesting is that 30% or 34 deaths occurred among people who were newly diagnosed in 2024, which reflects the number of cases who are presenting late or are delayed in linking into care. And of those 34, 7 were already enrolled in care at the time of death, and 5 were people who were injecting drug users. So what this really does highlight is the urgent need for earlier diagnosis and for us to really address the vulnerabilities faced by people who inject drugs, and really try to increase our efforts in engaging all of them into our treatment care program. So in terms of estimates, as you all know, those of us who work in HIV rely on estimates that are generated by UNAIDS. In 2024, before we took into consideration the influence of people who inject on our estimates, Fiji was estimated to have approximately 2,600 cases of HIV. However, when you took into consideration PWID as a risk factor, the estimates doubled to over 6,100, and this is as of December 2024. We've just had a recent revised estimates done in March this year, and this number has increased by 1,000. So we really are concerned about the large group of people who are currently not engaging in testing and in care. So the estimates have identified that in 2024, at least 1,600 people would have been infected with HIV. And our most recent estimates indicate that for every week, at least 40 new Fijians will be infected with HIV, so which is really quite concerning. So in terms of how we define this HIV outbreak, we use the Fiji CDC's definition for an outbreak as a result of an infectious disease. And the definition requires that in the previous 5 years, we are to show that there is a two standard deviations increase in the number of the number of cases we are reporting. So the CDC definition holds that in the last 5 years, we need to have shown the threshold for calling an outbreak was actually 430 cases. And Fiji met this threshold for an outbreak in June last year when we recorded 552 HIV cases. So by September 2024, Fiji had diagnosed 1,093 cases as of September 2024, and the numbers have increased as far as I am aware. And this increase in cases is 5 times higher than the previous average year. So our average number of cases we see in Fiji in the previous 5 years is about 215 cases. And we have a year-on-year variance of about 108 cases. So the number of cases of 1,093 diagnosed really does indicate to us that something serious is actually happening in terms of our HIV epidemic. Again, based on our clinic data, the initial surge was amongst people who inject drugs, but now there's growing evidence to indicate there is also an increase in transmission amongst MSM in Fiji, transgender population, mother-to-child transmission, and sex worker populations, which, unlike many other countries which have concentrated epidemics, these groups were usually low historically in Fiji, and the majority, just like in other low prevalence settings, were mostly in heterosexual populations. This epidemic has changed significantly in Fiji, and we're seeing an increase in rates of HIV in all population groups. So in terms of a quick analysis of our actual response program, Fiji's current prevention program focuses mainly on condom availability without any significant behavior change intervention programs throughout the country. We focus a lot on awareness campaigns and outreach to MSM, transgender, and sex workers, where we deliver condoms and provide awareness and offer testing. There are serious gaps in our programming. I'd just like to highlight some. There's no targeted interventions for adolescents, despite their high vulnerability. Combination prevention interventions are limited or missing for MSM, transgender sex workers, and those individuals who inject drugs, who is a new risk population in Fiji. And while PrEP is not currently available, there's widespread support amongst our population and our administrators and policymakers in support of PrEP. So we're really looking forward to rolling that out very soon. Fiji has a narcotics and HIV search strategy, which clearly outlines and emphasizes the importance of harm reduction, including needle and syringe programs. However, implementation is still quite slow and it has not been prioritized. With a focus on the introduction with the actual emphasis on rehabilitation programs. While I'd like to emphasize, while this is important, it is really critical that Fiji also consider introducing harm reduction programs. Otherwise, we will not really get on top of this HIV outbreak. Now, what we're really concerned about, based on the estimates that UNAIDS worked on in December last year, with the current HIV prevention interventions and with no additional interventions introduced, we can expect our HIV numbers to increase significantly to up to 25,000 in the next 5 years. So we really are concerned about a serious catastrophic outcome if we do not introduce high impact interventions for prevention in Fiji. So what are some of our concerns around access to diagnostics? So one of the concerns we have in Fiji, despite the availability of point-of-care confirmatory testing, all our confirmation testing requires that it is lab-based, and this creates significant delays in the time frame between when individuals get tested for HIV and when they actually get enrolled in care. And on average in Fiji, this is currently at 22 days. And as you all know, WHO recommends same day or as soon as possible introduction of treatment into once somebody has been diagnosed with HIV. We have a serious issue historically about stock out of test kits, and this really disrupts our services. It delays when we can actually put somebody on treatment. It affects our outreach programs. It also limits our linkage to care and follow-up for those who are actually identified to be screened positive for HIV. Stigma and legal barriers create a number of challenges in trying to scale up our testing efforts. And that's because sex worker populations and people who inject drugs is still criminalized in Fiji. and it reduces our uptake of testing, and it increases the lag time between somebody being diagnosed and then being put on treatment. So, really like to highlight, the treatment cascade. Unfortunately, Fiji does not have a full cascade to present because our data of recent times was not sufficient to develop a cascade. But based on the estimates, UNAIDS estimates in 2024, of the 6,100 people that are estimated to have HIV, Fiji is only currently Fiji has only put 35% of those who have been found to be HIV positive on treatment. And I think really just to make a comparison to what Dr. Gideon had shared with Papua New Guinea has been able to achieve 84% of people on treatment. So if you consider that Fiji has a population of only 1 million people and a population PLHIV estimates of only 6,000 and 6,100, we really do have a long way to go in terms of addressing the cascades. So, and I really just like just to highlight that 50% of all people living with HIV in Fiji are lost to follow-up, which means some of them have never been enrolled in care, or if they have been enrolled in care, have dropped out of treatment and care programs. And so we really need to scale up our efforts to re-engage people on treatment, or actually enroll people in care and start them on treatment as well. I totally agree with our colleague from PNG. We cannot treat ourselves out of this HIV epidemic. We need to really focus on prevention. However, for individual care and under the U=U initiative, we really do need to reduce the gap and bring this 35% of people on treatment up closer to 95%. In terms of data and surveillance, Fiji's HIV data systems are fragmented. It's still a very manual system, and it's largely non-functional, which creates several delays in the time in which we receive data in order to respond to. There is no unified HIV platform and no central M&E framework, making it very difficult to produce reliable national and subnational analysis. The current system cannot generate or visualize treatment cascades effectively, or track high-risk clusters or emerging transmission trends in real time, which is one of the reasons why we've identified this outbreak so late in the piece. Data gaps for key populations are an ongoing issue, especially for people who use drugs and especially people who inject drugs, which limits our ability to respond strategically with an effective program. We also face policy and legal barriers which restrict data sharing and the integration across various sectors. Some of our policy and structural barriers: criminalization, as I shared before, of sex work and drug users, pushes key populations underground. It limits our ability to reach them with services and also increases their HIV vulnerability. Gender disparities are a serious issue here, especially among adolescent girls, women, and poor reach transgender individuals and MSM are often excluded from targeted interventions. Stigma and discrimination is an ongoing issue, and it leads to internalized, community-based, and health setting stigma and discrimination, which really limits our ability to scale up testing, treatment, and our success with suppression of viral load. We have a serious escalating poverty issue in Fiji, serious intimate partner violence, which deepens our vulnerabilities and disrupts consistent access to care. Finally, there is still a limited understanding of what drives HIV transmissions in Fiji. Everything I presented to you, a lot of the information I've shared is anecdotal and is based on limited epidemiological data. And this is something we need to address very rapidly in order for us to respond effectively to this particular outbreak of HIV in Fiji. So some of the key lessons from Fiji: we've had a rapid growth of HIV transmissions, which can occur unnoticed, especially in hidden or criminalized populations like PWID and sex workers. Delayed data leads to delayed action. Surveillance and reporting systems must be strengthened with timely response. Multi-sectoral coordination is essential, and it's still very limited here in Fiji. Fiji is not HIV. It's not just a health issue, and it really does require collaboration across justice, education, and social services and communities. And this is an area which is still quite limited right now in our response. community-led programming is a game changer. And our response now is really to effectively engage with communities who have historically been very much the central part of our HIV response. However, over the years, they have fallen off our engagement in our HIV programming. Our programming capacity, both technical and human, needs to be scaled up, and we need to strengthen our HIV program to respond to the current changes in the HIV epidemic. Lastly, HIV programs must remain dynamic and adjust to the rapidly changing epidemiological shifts and emerging vulnerabilities in our country. And so opportunities in which we can benefit here in the region. So I think Fiji's outbreak really does expose challenges that are shared across the Pacific. So we need to create opportunities for regional collaboration. First, we can collaborate on PrEP scale-up, diagnostics, and strengthening supply chain to avoid stockouts and improve access across our islands. There is value in sharing protocols for tracing and re-engaging people who are lost to follow-up, because I believe this is a shared issue in many countries. Together, we can advocate for regional HIV funding and technical programming, as we used to have in the most recent past. And we need, as I believe, this really does help to address some cost efficiency issues that we all face. We also need to tackle legal and structural barriers, including stigma, criminalization, and data sharing restrictions. We also need to embrace South-South collaboration. And I really would just like to reflect on the smaller Pacific Island countries and working closely with Australian counterparts and also our colleagues from the PNG Department of Health and the PNG Health Society, who all work together to provide South-South collaboration in the past. So while Fiji is currently navigating this ongoing HIV outbreak, our national response is starting to gain some traction, and we're starting to gather strong technical and financial backing, particularly through the support of DFAT and MFAT, and we do really like to acknowledge them for this. We'd like to acknowledge that this crisis really does highlight some of the critical gaps and challenges that we all share across the Pacific. And I think we have an opportunity to learn from Fiji's experience. And I really do think that we need to be scaling up our prevention, strengthening surveillance right across the Pacific, ensuring access to treatment, and strengthen our policy reforms and decriminalization of key populations right across the Pacific. Our communities are central to this HIV response, and we really need to engage them more in our service delivery and helping us with decision making. So Fiji's decision really does remind us that speed, integration, and equity are essential to managing fast-moving epidemics. I really would just like to end by saying, let's ensure that Fiji's outbreak becomes a turning point for how we can do HIV programming, not just nationally, but across the Pacific. Thank you.
Thank you so much, Dr. Jason Mitchell, for a very comprehensive presentation regarding the Fiji outbreak. If there's no burning questions now, we'll go to our third speaker for the afternoon, Ms. Renata Ram. I don't see any hands coming up, so Renata, over to you.
Thank you so much. And I think Jason gave a really good segue into my session. So as an introduction, my name is Renata Ram. I work for UNAIDS. I've been with UNAIDS since 2017. I was formerly known as a country director, but due to changes within the organization, I'm now the UNAIDS Pacific HIV advisor. So without taking up too much time on my introduction, I'll go straight into the presentation. So Jason gave a really good in-depth situation analysis about the HIV epidemic in Fiji, or the HIV outbreak. And this is a warning bell for all of us, for the rest of the Pacific. And it's a real call for an urgent unified Pacific regional response. So the HIV outbreak in Fiji poses a significant health challenge. especially in the Pacific region, because we have so many vulnerabilities within the Pacific Island countries. Even though our numbers are small, we have so many critical issues that still have not been dealt with. And we must remember that Fiji's epidemic 5 years ago was considered low, something that was stable. Currently, the status of many other Pacific Island countries. And from the UNAIDS perspective, a regional HIV strategy is critical for effective response, collective action, evidence-based interventions, and community engagement. Community engagement is, as Jason also mentioned, is the key to actually getting some kind of change towards how we respond to HIV on the ground. Some of the vulnerabilities that exist within the Pacific Island countries are low condom use. We have very weak sexual education programs. There is an increase in injecting drug use in some countries. Low testing. We have low numbers because our testing rates are quite low as well. Also, some testing algorithms in many of the Pacific Island countries can pose issues. For example, not many countries within the Pacific do confirmatory tests within the country. And this further delays people getting into treatment, or even the blood samples being good enough to actually get the good quality for confirmatory testing as well. There is generally low HIV knowledge. There's still very high stigma around HIV. And lastly, poor data across the Pacific. And this poses an immediate threat to health security amongst the Pacific Island countries. Generally, the Pacific Island nations are lagging behind 2030 AIDS ending goals. We have a generation of young people with very inadequate knowledge of HIV. On top of this, we have challenges of limited resources, we have changing donor priorities, and weak health systems. Further to this, we have our key at-risk populations lacking tailored services. So this is just a snapshot of some of the countries' programmatic data, and I've put a note here that this is based on data that was shared with us on the 5th of November, 2024. As you can see, the numbers are low, and those who are identified or who are living with HIV in the Pacific Island countries have good enrollment into care, so basically 100% across the Pacific Island countries, which is good. However, we still need to, there's still a need to really get into identifying new cases. And this is a push that UNAIDS hopes to achieve within the coming years. So as we all know, Fiji is the hub of the Pacific. Fiji is a transit point for the vast migration between the Pacific, Australia, and New Zealand. And this is really a red flag for disrupting health security amongst countries. As spoken before, the existence of HIV drivers can have detrimental impacts on other Pacific Island countries if we do not address them soon enough. So in terms of injecting drug use, Fiji is well established in terms of identifying drug use in the country. And we are now seeing a growing trend in Tonga and Samoa. While efforts are mainly on border protection, there's still issues arising from domestic use, and that needs to be dealt with early. The impacts of drug use in communities are detrimental, and recent police seizures in Tonga and Solomon Island also indicate that there's some level of local consumption as well. And mind you, this is Fiji 5 years ago. Other vulnerabilities that exist within the Pacific is that we have high rates of STIs. the most common curable STIs, which are syphilis, gonorrhea, chlamydia, and also Hep B. So chlamydia rates a study showing that chlamydia rates amongst women 15 to 25 years are amongst the highest in the world, especially in Fiji, FSM, Samoa, Kiribati, Tonga, and Vanuatu. In addition, non-curable STIs, including herpes and HPV, are common. And unfortunately, we do not have reliable STI data in the region. And so most of the treatment is syndromic, with no systematic testing done in most countries. And there are a limited number of studies that really show the high STI rates across the Western Pacific region. Other vulnerabilities is our HIV knowledge and demand for service. In the Pacific region, HIV testing and demand for services are concerningly low, according to the Multiple Indicator Cluster Survey, which is known as MIX. So the data that we currently have on hand only covers Samoa, Tonga, and Fiji. So I'm just going to talk about these countries. In Samoa in 2019, the HIV knowledge is among 6% in men and 9% in women from ages 15 to 29. In Tonga, this was 9 and 15% for the same age group. In terms of HIV testing and knowledge of HIV status, in Samoa, between the 15 to 24-year age group, there's less than 4%. And in Tonga, this was reported as 2% for both female and male. In Fiji, the mixed survey in 2021, for women and men aged between 15 to 49 undergoing a HIV test in the last 12 months and who know their test results are very low at 7% and 4% respectively. But this is based on 2021 data, and this has obviously changed since then. Also, another vulnerability that we have are high-risk behaviors. So minimal use of condoms among key populations and young people. In Fiji, men who have sex with men has shown that only 24% used a condom at their last anal sex interaction. In the mixed survey, the survey revealed very low condom use amongst people who had multiple partners, stating that 24% of men and 9% of women reported using a condom at their last sexual encounter. And this is between the ages of 15 to 49. Condom use among young people, 15 to 24, with non-regular partners at the last sexual encounter was 28.7% for women and 39.8% for men. In Samoa, women reported 10% condom use at the last sexual encounter and men at 14%.
No, Renata, you're going backwards.
Yes, I can see. All right, based on what I've just shared in terms of the vulnerabilities that exist, why is urgent action needed? Rising HIV infections in Fiji signal a broader regional health crisis, and largely because of our interconnectedness and mobility within the region, this really calls for a unified approach. And this approach needs to be immediate. We need immediate action that can leverage international support to avert a health crisis. And a unified Pacific response is nothing new in terms of the HIV response. In 2006, we had the Pacific HIV and STI Response Fund, which averted what was expected to be a huge HIV epidemic that was expected within the Pacific. Because of the efforts made through that response fund, we averted a crisis. However, with the changing of donor priorities, the changing of health priorities within the various ministries of health across the Pacific region, we have kind of dropped the ball on our HIV and STI programs. And right now is the time that we really need to rethink our strategy and really put up our guard to ensure that the other Pacific Island countries are prepared to battle any incoming health security risks in terms of a HIV crisis. And we have so many solutions now. You know, this is not 20 years ago where you didn't have treatment, where getting tested was quite, it wasn't so accessible, wasn't so easy. Right now, you have rapid test kits, you have point of care testing, you can get your results within the same day if you follow the proper protocols that's needed and introduce these measures into your countries. So what we really recommend for a future vision for the Pacific is a unified regional effort and aligning with UNAIDS 2030 goals. What's really needed is strengthened government ownership and community leadership. Another thing is that we really need to modernize our HIV program. Right now, most countries are operating on a HIV program that they incorporated 20 years ago. We need to get up to speed. We need to have new interventions. We need PrEP in the country. We need point of care testing available. In countries that are starting to see some level of injecting drug use, we need to have harm reduction programs in the country. These are some things that Pacific Island countries need to start thinking about. Also, we need to do this in the Pacific way. We need to have a Pacific regional strategy to mitigate these new infections and work together to help each other out. So I'm just going to leave you with this slide. I know I don't have much time. So this is the global AIDS strategy and the priority and result areas. There are three main result areas that looks at services, it looks at breaking down barriers, and it also looks at sustainability in terms of a fully resourced HIV response. And these are the areas that we really need to pick up in modernizing our HIV response and seeing how we can improve on prevention, on services, really looking at our stigma and discrimination. Many of the countries still have punitive laws, still have strong anti-LGBTQ views. And also, lastly, in terms of sustainability, we really need to look at how we can help ourselves through domestic funding. Right now, most, or if not all, HIV programs across the Pacific are largely dependent on Global Fund. 100% of the funding comes from Global Fund. We need to see how we can start mobilizing domestic funds to actually supporting a fully integrated HIV program. So that's all I have to share for now. And I look forward to any questions. Thank you.
So much, Renata. And to the three speakers, that's just fantastic work. And happening in the region, but challenging times for us going forward. Look, I know we're just on time, and I'd like to just open the floor to a few questions. If I may welcome Sir Professor Colin Tuitonga, President of the New Zealand College of Public Health, to perhaps say something, make some comments or ask questions. Over to you, Colin.
Well, thanks very much, Aumea. I've put a few comments in the chat, but I want to thank Jason, Dr. Mitchell, Nano, Gideon, and Renata for the wonderful presentation. May I suggest that this is, I think we've got ourselves into a bit of a false sense of security. You know, for the longest time, we've kept saying, you know, the Pacific is a low prevalence region, rah, rah, rah. But, you know, the risk factors are always there. The legal restrictions, poverty, church and cultural thingies, it was always going to blow up at some point. My practical suggestion is this needs to go Jason, Dr. Jamesa and the Minister Lalambalavu, similarly Papua New Guinea, to go to the heads of health and the ministers of health. That's a practical thing that, and make the case like you've just made about a renewed effort, some additional interventions, some resourcing, a regional, all of the good things that you've raised today. So that's a very practical, and you may already have this in hand, but that's my suggestion. And of course, we will always try to be as helpful as we can. Sorry, Aumea, and to say thank you to you and Sai for bringing this very useful, timely event together. So thank you very much, everyone.
Do we have any other persons keen to contribute or?
If I may respond to Sir Colin. So UNAIDS will be making a presentation at the heads of health, the upcoming heads of health. Also at the upcoming Ministers of Health meeting through a joint effort between WHO and UNAIDS, we'll be having a side event and making a very strong intervention at the Ministers of Health for the need for a Pacific response to the HIV situation.
So, Dr. Jeff, University of Otago.
Yeah, thanks very much. And thank you everyone for the really interesting but very sobering presentations. I guess a question directed particularly at Fiji and Jason and Renata perhaps. You commented a little bit on harm reduction, and I'm thinking about needle exchange and so on. To what extent is the emerging situation with these increasing exposure diagnosis, etc., changing the views that there may be around the acceptability or unacceptability of harm reduction as an option, for example, in Fiji?
But maybe I'll address that question. So Fiji's got two strategies that recommends the introduction of harm reduction programs, which include needle and syringe programs through an exchange approach. And for some reason, there has been some stepping back from those strategies in the sense that there's a bit of a resistance to introducing needle and syringe programs into the country. Those of us who work in HIV, who are trying to control the epidemic, feel very strongly that these interventions are absolutely essential for controlling this epidemic. The other interventions that are part of the four pillars of the narcotic strategy that Fiji's cabinet has already endorsed is essential, but we cannot control the HIV epidemic without introducing needle and syringe programs. About 50% of all our infections in the country are now as a result of intravenous drug use. We have, what I haven't presented here, and Renata's touched on it, but we have a neglected STI situation here. And as you know, you put STIs and low condom use together and then untreated people, and it's a disaster. And then what we don't also have here, what we have not touched on as well, is that there's now an outbreak of Hep C as well in this country, in the absence of any program, in the absence of any treatment in this country. So, you know, all the things that could go wrong with intravenous drug use, and we do know from a rapid assessment that's just started here, is that there's two issues happening here in Fiji. One is the sharing of unsterile needles and syringes by people who use drugs. There are some cultural interesting ways in which people use drugs here in Fiji. Families share needles together. Older cousins, fathers and sons, cousins and younger ones. This is explaining the adolescent number, because many of our adolescents who are now becoming HIV positive are not sexually active. So it sort of, you know, puts all of that together. But we have a serious issue here. And I think what we need to do is take our head out of the sand and really face the music and address the situations on the ground. The other thing that we have with our drug users is the sharing of blood. You might see it in the media as Bluetoothing. I think we get a little bit carried away by labeling things, but basically what it is blood sharing. They're using it to, you know, share, to actually, you know, in most countries, they use water to mix the drugs. They use blood here. And the belief behind a lot of that is that there is some some drugs in your blood. And so if I add more drugs to it, then we have a stronger potent. I think everyone knows this. It's not a practice that's unique to Fiji, but it's certainly well used here. So of course, we really do have a serious situation here where you have these practices, no harm reduction programs, punitive legislation around people who use drugs. It is simply a recipe for disaster. And I cannot emphasize enough through the work that I do, how important it is for Fiji to really think about introducing harm reduction. But I would like to say one of the questions here, what's the future of PrEP in the Pacific? There's no, PrEP is most likely going to be introduced for serodiscordant couples, very high level answer here for other Pacific countries. But in Fiji, UNAIDS has just commissioned a feasibility study for PrEP. So the beauty which we have here in Fiji, which I worked in Southeast Asia, they were quite resistant to PrEP. Fiji is very accepting of PrEP versus needle and syringe programs. So that's a win for us. But again, it's not going to help us with the situation of drug users here in the country. But it's a win for us, especially when we have increase in sex workers for the first time historically, increase in MSM who are now becoming, there's outbreaks in MSM populations, which historically they were low risk population group. Transgender numbers are also increasing. So, we have a number of issues right across the board. And I think what is one of our greatest challenges here is that the program itself has not morphed to meet the needs of the current epidemic. It's not a fault of the program. It's just that we just need to catch up. And that's a challenge for our task force to really respond to this.
If I can add to the harm reduction side of things and the appetite from the communities, or not the communities, the government here in Fiji. So I was part of this rapid assessment. We just had a consultation this morning, and we did have a few ministries out there. And it's just clear the resistance comes from the lack of understanding of what a needle syringe program is, right? And they see it as encouraging the use. A needle syringe program is viewed as condom distribution, where you're just going out and giving out needles. And I feel that it is our part to actually help bridge this understanding and build that sensitization. And in terms of the international community, in terms of New Zealand, of our other partners who have, other countries who have successfully managed this, we need better advocacy from their end, the need for study exchange programs, and not just for the ministries of health. We need a whole of government. We need decision makers to be there to see how it works, and also to see, also to have the role of the church. How can they play a huge role in terms of harm reduction? We see that in Australia, the Uniting Church runs some of these harm reduction programs. So I think it's the lack of understanding is where the resistance is coming from.
Thank you. Our final question from Felicity Williamson, who works in this space in New Zealand. Over to you, Felicity.
Kia ora, thank you. Apologies, my camera's not working, but a huge thank you to all the speakers for your insights and all the work that you're doing in the Pacific. So I'm the STI lead for the NPHS Northern Region as a medical officer of health, which includes complex HIV. And I guess really my thinking is how can we support, in particular, our Pacific community in New Zealand in this space, recognizing, there'll be people coming and going from different Pacific Island nations, and very much connected to our communities here. And, how can we support people to get tested and to link into treatment, recognizing that we probably have better access in New Zealand than in many of the Pacific places. So would love to collaborate further going forward. And if you have any kind of thoughts or tips on what we can do to support our Pacific populations and those that might be fluid between the Pacific countries and New Zealand.
Thank you for that. I think maybe just to share a quick story, I'm I did some work. I did some work in Vanuatu recently, and one of the things we did was to interview people living with HIV in the country. We saw one PLHIV female who shared how she would often go to New Zealand. Her partner is actually a seasonal worker, and she would go to visit him, and that was when she would often get her CD4 counts done, her viral load done. She would get free access to services that the New Zealand government made available to Pacific Islanders who were visiting. She was able to replenish the antiretroviral drugs, especially if there were any stockouts on the island. She would be able to get that from New Zealand. So we do know that, you know, New Zealand is quite generous with Pacific Islanders that are visiting, and it would be great if maybe these services are, you know, advertised so that those who are visiting the country, they have this opportunity to get access to testing and to be initiated on treatment. That would be really fantastic. And I'd say, I think at this point in time, given that the numbers are so high here in Fiji, that we're going to start seeing more and more people, you know, becoming positive who are visiting New Zealand from Fiji. I think what we don't want is for them to be lost to follow-up when they return to Fiji. So perhaps we need to be having discussions about how we can engage with the Fiji Ministry of Health in a return referral system so that people don't get lost and that they continue with their treatment once they come home. It's quite common for people to get on treatment when they're abroad and not continue once they run out of drugs when they return to Fiji. So we really do want to reduce that, because as much as we cannot rely on the treatment program to solve our HIV epidemic here, it's still essential for secondary prevention and also for just the general health of an individual. So thank you very much for asking that question. It really does highlight the concern from New Zealand. We really do appreciate your support. Thank you.
We'll be in touch to see what we can do. Thank you so much, team.
And I think the other part that is frequently overlooked is the fact that we have many New Zealand residents traveling to and from Fiji as visitors, tourists, or visiting families. But I think we need to also consider the tourist population who we know may possibly engage in I forgot what I was going to say, but engage in sexual activities or even maybe drug use. Who's to say how people enjoy life or visits or trips to other countries. And so I do think in the New Zealand context, the lifting of our implementation plans around our strategy in New Zealand is important to continue. And I'm thinking also in some conversations with our speakers today that there is a thought, perhaps Felicity, whether there's some, where there's a possible appetite from our colleagues here in New Zealand to support or find a way to provide some support. I don't see any free trips to Fiji in the near future, nor to Papua New Guinea, but using our collegial relationships and partnerships and possibly through the New Zealand College of Public Health or the sexual health services in this country, where we can provide some real support or tangible support to Jason and Renata, as well as to Dr. Gideon in Papua New Guinea. I suppose that we've come to the end of this very informative session, and I just hope everyone that's joined us today has enjoyed this. And yes, there's lots of work to do in the region. We send you all our love to the presenters. Many of us visit the Pacific, live in the Pacific as well as New Zealand, and we hope one day we can come together to address this major issue that's challenging our health systems in the region. Kia ora and kia manuia to everyone. Thank you very much.